Okay, multiple gestations. Okay, what is multiple gestation? It is more than one fetus per pregnancy. Okay, so maybe twins or triploids, etc. Okay, the incidence of multiple gestations is about 1 to 80. Okay, this is approximately around the world, but every different or each different place has its own numbers. Okay, so it is an average of 180, but some places like African Americans they have a lot more than 180. Okay, so this is the incidence. Let's now talk about the twins. Actually, we have two types of twins. A type that result from two ova that are fertilized, two separate ova that are fertilized, and the other type is about one fertilized ovum that divides into two after that. Okay, so in the first type we have two sperms that fertilize two ova, okay, to make two fetuses. The second type is one ova or one sperm that fertilize one ovum to be divided after that to make two fetuses. Okay, the first type, that is from two separate ovums and two sperms, we call dizygotic. Okay, and the second type, which is from one ovum that fertilized by one sperm and then divide, is monozygotic. Mono, one, dizygotic, two, di. Okay, the dizygotic risk factors are actually family history of previous multiple gestations, clomiphene citrates, PCOS treatment or fertility treatment drugs, okay, in vitro fertilization, African American. Okay, these all are risk factors of dizygotic. But in monozygotic there is no inheritable method of giving that type. Okay, so it is not familial monozygotic multiple gestation. Okay, so the dizygotic type, in the dizygotic type, the fetus will be dichorionic diamniotic. What do we mean by dichorionic? It means that each baby from the twins has his own placenta. Okay, chorionic opposite placenta. Diamniotic means that each baby will has his own amniotic sac. Okay, so in the dizygotic baby that results from two ovums and two sperms, we will have always two placentas and two amniotic sacs. But in monozygotics babies, we may have a lot of possibilities. Okay, first of all, we may have one placenta or two placentas. One placenta means monochorionic, two placentas dichorionic. Okay, and that one placenta may have monoamniotic, one amniotic sac, or the baby may has one placenta and diamniotic, two amniotic sac. So he may be with one placenta and one amniotic sac, or both of them they may be with two placentas. I'm sorry, one placenta and two amniotic sac. Okay, so in the case of one placenta and one amniotic sac, we call it monochorionic and monoamniotic twins. In the case of one placenta and two amniotic sac, monochorionic diamniotic twins. Also, the fetus may be with two placentas or dichorionic, and that two placentas may have one or 2 amniotic sac. We call it diamniotic. So it is dichorionic diamniotic baby, or it may has rarely, very rarely, 1 amniotic sac, dichorionic monoamniotic. Okay, and that depends on what? It depends on the stage in which the separation occurs. Okay, if the separation occurs in the first 3 days, okay, from the day 1 to 3, then the patient or the both of babies will be with 2 placentas and 2 amniotic sac. Okay, so they will be dichorionic diamniotic, and this is in the case of separation at the first 3 days before differentiation of trophoplasts, and that constitute about 30% of all cases. Okay, if the separation was or is on the days between the 3 and 7, okay, we will have monochorionic, 1 placenta but 2 amniotic sac, okay, and that constitutes about 7% of all cases. Okay, and this happens after differentiation of a trophoplast and before amniotic sacs differentiation. Okay, the first case, when we have 2 placentas and 2 sacs, we said that it happens in the case of separation before differentiation of a trophoplast, before differentiation of the placentas. Okay, so we have 2 placentas, and here in the case of 1 placenta we have already differentiated the trophoplast, so it will not separate anymore at the days 3 to 7. Okay, but the amniotic sac is not yet differentiated, so we will have 2 amniotic sacs and 1 placenta, and 2 amniotic sac, monochorionic and diamniotic. Okay, what if separation happens after that? Okay, we will have 1 placenta, of course, and one amniotic sac. Okay, so will be monochorionic and monoamniotic, and that if the separation happens at the days 7 to 13. Okay, monochorionic, 1 placenta and 1 amniotic sac, monoamniotic. Okay, and that constitutes about just 1% of all cases of multiple gestation. And the question now is, what if separation happens after 15 days? Okay, so we will have a very rare case which we call conjoint twins. Okay, conjoint twins. Actually, it's very the most dangerous, and about 40 to 60% of babies will die. This is in the case of monoamniotic and monochorionic, but in the case of conjoint babies, we will even have more mortality rates. Okay, so this is about the types or classification of twins. In the monochorionic diamniotic, between the 3 and 7 days fetuses or twins, we will have a special case of what we call twins transfusion syndrome. Transfusion syndrome. Okay, and let me remind you that 70% of all cases is monochorionic, okay, diamniotic. So what is twins transfusion syndrome? It's a case of, okay, a blood supply that goes to or from one fetus to the other. So we have one donor baby and the other is recipient. Okay, one donor and the other is recipient. The donor baby or fetus will be small, okay, as expected, anemic, also as expected, oligohydramnios, oligoamniotic, and choked as expected. But the other baby or the recipient will be large baby, polycythemic, okay, hypertensive, polyhydramnic, okay, with a fluid collection in his body, ascites, and heart failure. Okay, the case will be worst in the case of recipient in twins transfusion syndrome. Okay, the donor fetus will be in better situation than recipient. Actually, in most of cases, the recipient, among the death of this case, the recipient will die in more rates than the donor baby. Okay, what is the management of a twins transfusion syndrome? First of all, we have to do fluid reduction to reduce the distension of the uterus and the abnormal contractions of the uterus due to overdistension. Okay, in severe cases, we may do what we call laser ablation. In laser ablation, actually, we ablate the vessels that supply the large baby, and by this we prevent the complications of twins transfusion syndrome to occur. Okay, and in very severe cases we have to deliver the babies. Okay, this is twins transfusion syndrome. And now let's move to diagnosis. How do we diagnose multiple gestation? First of all, it is indicated by rapid uterine growth, abnormal rapid uterine growth. Okay, in one gestation we have a uterine growth, but in multiple gestation we have a rapid uterine growth that is not expected in normal gestation. Okay, excessive weight gain. Okay, family history of multiple gestations, reproductive technology, the usage of in vitro fertilization or clomiphene citrate or any other things that, okay, rapid beta-HCG raising or placenta lactogen hormone also. All these things, rapid uterine growth, excessive weight gain, and family histories, and excessive pregnancy symptoms, physiological or pathological, okay, indicates that we have multiple gestation, and we confirm that by doing early ultrasound. Okay, in rare cases they discover multiple gestation during delivery, in very rare cases. Okay, so now let's move to complications of multiple gestation. Okay, to summarize it, in multiple gestation all complications of normal pregnancy will increase. Okay, even the physiological symptoms will increase: cervical incompetence, cord prolapse, a placenta previa, okay, and all things you can imagine in normal pregnancy. All complications will be exaggerated by multiple gestation. Okay, and we will have much more preterm labor, most of times between 36 and 37 weeks. Most of ladies will deliver at this period. Okay, what is the management of multiple gestation? First of all, we have to do good antenatal care, ultrasound every 4 weeks, more folic acid administration, and good nutrition. Okay, the mode of delivery, the most important thing to take care of. Okay, we have 4 possibilities to have the first baby to be vertex, the second to be vertex, the first to be vertex, second to be breech, the first to be breech and second to be breech, the first to be breech and second to be vertex. Okay, in the case of the first baby, a vertex a presentation, whatever the second baby is, we will try to have normal vaginal delivery. If it fails, then we move to cesarean section. Okay, in the case of breech presentation of the first baby, most of cases we will start with cesarean section. And as you know all, if we have any other complications with twins or with multiple gestation, cesarean section is the mode of delivery. When to deliver? We wait term 38 weeks in normal cases with no complications, but most of cases will deliver between 36 and 37 weeks. This is all about multiple gestations. Thank you for watching. See you in the next video.